Yeah, so there is one study being done in our Institute of Nephrology at MMC. They are following all the patients who have undergone dialysis. So maybe whether they're prone for any chronic kidney disease also later. It's a long-term study. So I just request that young boy, is
yes, sir.
So you can just follow him. Thank you.
Sure, sir.
Thank you, sir. Please come. Dr. Professor Ratan Kumar from Tirunelveli Medical.
Good afternoon to everyone, respected panelists. So I am presenting an interesting case of snakebite from Tirunelveli Medical College Hospital. As told by the previous speaker, in neurotoxic snakebite we usually see descending type of paralysis from ptosis to respiratory paralysis leading on to intubation. Or we have presented some cases of coagulopathy producing intracerebral hemorrhage and stroke-like picture. We have also presented infarct following snakebite due to vasculitis. It is quite different case. Next slide, please. Name Priya, age 28, self-employed from Sangarankoil. Next slide. The patient went to Sangarankoil GH with alleged history of snakebite, cobra bite, over left foot around 8:30 p.m. near her residence on 25/3/2025. The patient developed complaints of giddiness, difficulty in breathing and blurring of vision on her way to hospital. On arrival at Sangarankoil GH, the patient suddenly lost consciousness and was intubated in view of impending respiratory failure and was given 20 vials of ASV and 2 doses of atropine and neostigmine, following which she was referred to TVMCH for further management. Next slide. The patient received in TVMCH in intubated state around 11:40 p.m. with left lower limb cellulitis and ptosis. On arrival, the patient had no history of weakness of limbs, no history of seizures, and no history of bleeding from the nasal mucosa or from this bite site. The patient was awake on medical ventilation and obeys commands and afebrile. BP was 100/60, pulse was 97, SpO2 was 99, and whole blood clotting time was less than 20 minutes. Cardiovascular respiratory system was normal. She was awake and obeyed commands and moves all the 4 limbs, and cellulitis present up to middle 1/3 of the left leg. In view of progressing cellulitis, further 10 vials of ASV was given. The improvement was observed after 3 doses of atropine and neostigmine, which was subsequently tapered. On the day 2, the patient was extubated and respiratory efforts were normal. After that, the patient was kept in observation in IMCU. Later, she shifted to M2 medicine ward on day 5, following which the patient presented with bilateral upper limb weakness on the day 7 in the form of difficulty in holding objects, mixing up of the food and combing the hair, which was not associated with respiratory difficulty or fever or bleeding manifestation. Next slide. No history of sensory disturbance, no history of fever, trauma, or memory disturbance, or loss of consciousness, or behavioral disturbance, sleep disturbance, hallucination, or no history of abdominal pain, palpitation, headache, projectile vomiting. Next slide. No history of slipping while walking, no history of tripping over toes while walking, no history of difficulty in toe walking, no history of difficulty in clearing the obstacles on the ground, no history of buckling of knees while walking, no history of difficulty in getting up from the squatting posture, no history of difficulty in getting up from the chair, no history of difficulty in climbing upstairs and downstairs. There were no history suggestive of lower limb weakness. Next. No history of hard of hearing or difficulty in swallowing, choking spells, or hoarseness of voice, nasal regurgitation, or difficulty in turning the head, difficulty in rolling over the tongue. Next. Able to feel the bladder sensation, able to initiate the maturation, no history of frequency of maturation or incomplete bladder emptying, no history of any interrupted stream of urine, no history of bowel incontinence, no history of abnormal sweating, dryness of the skin. Next slide, please. Not a known case of diabetes, hypertension, or bronchial asthma, no history of chronic steroid abuse, no past history of any illness. Next slide. Personal history was quite normal and family history not relevant. Menstrual history not married. Menarche at 14 years. Last menstrual period 18-3. No history of menorrhagia or dysmenorrhea. Next is general examination. She was moderately built and nourished. No fasciculation. No external markers for syphilis, HIV, tuberculosis. No peripheral nerve thickening, no neuromuscular, neurocutaneous markers. Next slide. Local examination, swelling and tenderness were present over lower one-third of the left leg. Warmth was present, no regional lymphadenopathy. Next. Next slide. Pulse was normal. Next. Blood pressure was normal, temperature JVP not elevated. Respiration was quite normal. Next. Higher mental functions were completely normal. Next. Cranial nerves, first, second, third nerve were normal. Next. Fifth nerve, seventh, sixth nerve, seventh nerve, and eighth nerve normal. Next. Ninth, 10th, 11th nerve, 12th nerve also normal. Next. Spinomotor system. Arm, there is no weakness, no small muscle wasting. Next. Upper limb, right and left hypotonia, and lower limb normal. Next. The shoulder joint, the power was all the movements, abduction, adduction, flexion, extension, internal rotation, external rotation were 4/5 on right side, left side 3/5. And elbow joint also and wrist joint 3/5 on the right side and left side 2/5. And finger grip, hand grip is 20% only. Next. Lower limb, the power was completely normal. Next. All the reflexes were present. Plantar was flexor. Deep tendon reflexes, biceps, triceps present. Knee jerk 2+, ankle jerk also 2+. Next. Finger nose test not able to perform in the upper limb, but lower limb coordination was normal. Next. Sensory system was completely normal, including cortical sensation. Next. No signs of meningeal irritation, spine and cranium abnormality. Next. Other system examination normal. Next.
Anything positive, please highlight on that.
Blood count analysis normal. Next. So urea creatinine and electrolytes normal. Next. And the liver function also serially normal. Next. Urine analysis also normal. CPK was 1748. Next. Coagulation profile was also normal. Next. This is the X-ray chest. Next. This is the ECG. Next. So we were quite confused where we could fix the lesion. This is not vasculitis that causes a stroke, or it is not a hemorrhage, intracerebral hemorrhage. Patient was completely all right. Only bilateral upper limb weakness where we could fix the lesion. And this case was actually kept in the exam. Balamurugan sir knows. And the final MBBS student told all the finding correctly. And we ordered for MRI immediately. MRI showed. Next. Next. So it is a toxin-induced leukoencephalopathy. Then we went for the so many references in the journals. Next. A nerve conduction study, polyradiculosensory motor demyelinating neuropathy with secondary axonal neuropathy, predominantly brachial neuropathy. That explains all the above features. Next. She was treated with methylprednisolone, pulse therapy for 3 days and completely recovered and discharged. Next. The patient is currently on prednisolone 5 milligram. That was 8 milligram, 8 into 5, 40 milligram on the time of discharge. Then it was tapered and rapid improvement. Next. These are some of the articles showing acute demyelinating polyradiculoneuropathy following the snake bite. So when following any toxin exposure, when we are not able to fix the lesion at any point of time, it's cortical or subcortical or brainstem or cerebellum or spinal cord or radicals or anterior horn cell or muscle or neuromuscular junction, the most common thing we have to think is leukoencephalopathy. It can be quite common following methotrexate and also cyclosporine, 5-fluorouracil and other chemotherapeutic agents. And also heroin-induced encephalopathy is very much reported, and a few cases of snake bite-induced toxic leukoencephalopathy is reported. So I thought when Balamurugan sir asked me to present, it will be nice. Thank you, sir. Next slide. This is another case report. Next slide. Thank you, sir.
Well done, well done, well done. We just listened to a thorough MD General Medicine internal examination.
Thank you,
So
sir.
clear.
So the CSF,
CSF we have not done, sir, because one reason is patient drastically improved. So at the time of the weakness also, she was quite conscious and recovered completely from the respiratory paralysis. So the parents were not willing for CSF analysis. Now conduction study, polyradiculoneuropathy, mainly involving brachial plex. Thank you, sir.
Can it be a snake venom induced serum sickness induced sometimes the encephalomyelitis can be a feature of both venom as well as the serum sickness, excessive dose of venom can induce.
Yes, sir. The
Is
report.
it
So when we go through the literature, it has been clearly mentioned as sir told, but I have not mentioned because both toxin as well as the drug per se, ASV, can produce.
before going for a full-fledged immunosuppressants like steroids and other things, I think it's better to do a CSF analysis and rule out other infections before going for a full-fledged
CSF,
immunomodulation
the
therapy.
patient's attenders were not completely
Sometimes
willing.
it is concurrent tuberculosis meningitis or something else.
Yes,
Will
sir,
be
but
going on.
she's on close follow-up, sir. We will convince and do to rule out other
But
infections.
it is on protocol wise. I think it's better to go for a CSF analysis at least to
Yes.
proceed before going for such a massive immunosuppressant therapy because it can worsen the scenario altogether. So of course the local
See, when
arrangement with the patient attenders and I think that is a different. But something goes wrong if they ask us, we cannot answer anything. So as per the
Actually,
protocol, we should go for a CSF analysis and rule out other possible infective etiologies before going for the suppression. That will be better one.
Thank you, sir. Thank you,
Well
sir.
done. Thank you. Please come.
can be presented, sir.